We start with nutrition. So summary, why do we eat?
For energy.
Okay, so we need to eat not just for survival, but also for pleasure, right? Imagine if eating was not pleasurable. Would anyone want to eat? No, we will all die. Okay, so it's pleasurable. We are given, God-given gift, to enjoy food. So we get to chew it, savor the flavor, swallow it, then we digest, and then we eliminate it. We take these things for granted. Every day, for however old you are, you've been eating, eliminating, as if, you'll have them forever. Some people, that is not the case. Some people lose the ability to chew, swallow, and digest food. Okay, so a combination of these, either temporarily or permanently. So here comes nutrition modalities. How else can we feed these patients, therefore? So here comes nutrition modalities. So we can feed them enterally, meaning through the GI tract. In order to accomplish this, one prerequisite is the GI tract must be functional. Okay, so the only thing absent is the ability to chew and swallow. There are various reasons for that. The textbook lists down various reasons. It's usually cognitive ability. So let's say they had a massive stroke, loses the ability to swallow or chew safely, or any traumatic brain injury, for instance, same result. It could also be from other diseases wherein you lose the ability to chew and or swallow. Let's say you had throat cancer, for instance. So it could be temporary, or meaning you're getting radiation therapy. It's too painful to swallow. You're given a temporary feeding tube. Okay, so various reasons, right? So they do one of these things, one or both. So they affect food, fluid intake, and then jeopardize general health. So here comes our choice. So if a person doesn't have any advance directive against artificial nutrition, then they will be given one. So if you don't have one yet and you have a plan wherein you have wishes wherein I don't want to live like that, I don't want to be fed through a tube. Okay, so put it in writing, right? Entrust it somewhere, a lawyer, whoever you trust. Okay? If you don't trust your family to follow your wishes, then put it in a legal document, right? That way you force them to follow your wishes, not theirs. Right. So the advantage of enteral nutrition versus parenteral is, of course, this one is more natural, right? So we just do it modified, wherein instead of chewing and swallowing it, we give it through a tube. Of course, that requires the nutrition to be modified. Unlike before, wherein we literally, this was in the 70s, 80s, okay? We pureed the food and then we shoved it down the patient's feeding tube, okay? So because of complications, the tube got damaged as a result. So now we have commercial feedings, which are more healthy. Okay? These are specifically designed for the patient's nutritional needs, made by nutritionists, dietitians. They're accurate we have one for every condition. So for people with kidney disease, people with diabetes, people with certain malabsorption problems. Okay, so these are specifically designed for various needs. Yes.
I just want to know, are there lactose intolerant feeds?
Yes, there are different feedings. Some, most I know, some I've never even heard of. Like I see a formula come to the floor wherein they special ordered it. I've never seen this before. Okay, so yes, there are many types of feedings. We have Jevity, which is mostly used for everybody. Then we've got Nepro for kidney failure patients. We are on dialysis. Then we have Glucerna for diabetics. but there are several others. Okay, so both the three I mentioned, Gevity, Glucerna, Nepro, are the most commonly used formulas in the hospital. But again, there are countless more, right? Again, hence depends on the patient's needs. If they don't have what you have, a nutritionist can actually design one for you. Okay, so he or she, a dietitian, can um, create one. Okay, they can mix one for you. So other advantages of enteral feeding is, besides it being natural, cost effective. Okay, you don't need a central line for this. There's less side effects compared to parenteral nutrition. The GI tract is preserved, meaning you still absorb and poop like normal. Again, the only thing lost is the ability to chew and swallow. That's the only thing we're bypassing here. And maintain normal insulin and glucagon ratios. Okay, because the food is natural. Okay, it's not like parenteral nutrition, wherein the source of carbohydrate is 10 to 20% dextrose. Okay, so that's not natural. Okay, there's no food that is that concentrated. Okay, so our responsibilities, well, it depends. Where is the feeding tube? Is it through the nose? Is it through the stomach? Is the tube laying in the stomach? Is it in the duodenum? Is it in the jejunum? Depends. Okay. Tube insertion depends. What tube are we talking about? So on the recording, I mentioned Dobhoff feeding tubes. These are small bore feeding tubes. We can insert them within a few minutes. What will take long is the X-ray confirmation, because we need to check placement by X-ray. Afterwards, we can check placement by two other means. One is through CO2, end-tidal CO2, meaning at the end of the tube, we detect the levels of CO2. So if the CO2 levels are high, where is the tube? It's in the lung. If the CO2 levels are low or normal, it's in the stomach. What if it's we can also check the pH of the gastric contents. So we will aspirate a sample of the pH and then test the pH of that liquid. If it's acidic, then it must be in the stomach. If it's slightly alkaline, it has to be somewhere else. We don't know, but it's not in the stomach. Okay. So that's confirming placement. Again, what are the three ways we can confirm placement? First is X-ray. Second, pH testing. Third is CO2, end-tidal CO2 detection. If you don't know that, that's called end-tidal. And like the end, end-tidal CO2 detection. What does that mean again? We will use a capnometer. It's an instrument that will detect CO2 levels. Okay. I know nursing homes still use the auscultation method. We call that
Listening to.
there's a term for that. Air insufflation. Okay, so it's called air insufflation. Insufflation is spelled like this. Insufflation. Yes, this is used in nursing home, long-term care, and some hospitals, but this has not been shown to be evidence-based, because regardless of where the tube was, you will still hear that whoosh sound. It did not matter whether the tube was in the esophagus, in the lung, or in the stomach. When you push air into the tube and listen to it, you will hear the same sound. So it did not make any difference. Did it confirm placement? Not at all. So what are the three reliable ones? X-ray, end-tidal CO2 detection, and gastric pH testing. Okay. Of course, for every use, because we're supposed to check placement every time before we use the tube. So therefore, And we do X-ray 3 times a day?
No.
Okay, so X-ray is only used for after initial placement. Okay, to confirm initial placement, chest X-ray. Hearing obstruction, we have, of course, techniques would be you flush the tube, okay, with 30 mLs of air or water. What type of water? Best practice is sterile distilled water, but tap water should be fine, right? I mean, do we drink sterile distilled water?
No.
No. However, best practice is we use sterile distilled water, and the container should only be good for 24 hours. Okay, so what do we do with the bottle as soon as we open it? Date it and then discard after 24 hours. Same thing with any leftover tubing, because not all patients will receive pump feeding. Some people will have bolus feeding, which comes from a can. So if it's a can, then of course there might be some leftovers, but make sure the leftovers are discarded after 24 hours. Okay, another way to clear obstruction is let's go to the causes of obstruction first. Causes of obstruction can be medications. Okay, medications given through a feeding tube should be liquid.
Of course.
It should be liquid. However, some medications don't have a liquid form, so we are forced to crush it and dissolve it in liquid. Okay. The problem with that is practitioners, I'm talking about nurses, we get lazy. Okay, we're in a hurry. We do not crush it properly, so we still have clogs. And best practice is 1 medication per container, 1 medication per cup. But what do nurses do? Combine 12, 20 medications into 1 cup. Okay, so of course it's going to clog the tube, especially small bore Dobhoff feeding tubes. Okay, peg tubes hardly get clogged, but I've seen some nurses try very hard, they still clog it. Okay, yes, ma'am.
Sorry, 1 medication for like a cup of water or? for
Yes.
Medication cup?
Per
It's a
cup. Per medicine cup.
Per medicine.
Mhm. All right, so those are the causes, okay, or nurses just send the patient back to their room or to the hospital or anywhere without flushing the tube. So you're supposed to flush before and after using it. So when you're done using it, meaning the feeding is over, what should you do? Flush it. Okay, but I've seen it a lot. I receive patients from the nursing home. There's clearly formula in the peg tube. Okay, clearly was never flushed. Leaving it for the next shift to unclog. Okay, it's already clogged. Now it's your problem now. Okay. I never think about the patient. How's the patient going to eat now if the tube is clogged? All right, so we do have commercial declogging agents. Follow agency policy. Some agencies, and it is approved, they use soda. Okay, so they use ginger ale, other similar carbonated beverages to unclog. But the best practice, of course, is they have clog zappers. These are commercially available solutions, okay, to unclog feeding tubes. A warning, if your patient has the Dobhoff, I showed a picture on the recording. These are small. They are no bigger than cord, this charging cord. That's how thick the diameter of the tube is. Very small, so you can understand why they easily clog. Okay, so if you, some medications cannot be crushed. For example, number 1 example are
Sustained release.
capsules. Okay, capsules. Tamsulosin, Flomax, esomeprazole, or what is that, Nexium? Okay, or no other capsules, antibiotic capsules. They are in granules. Okay, they're not in powder. So how can you flush granules through a small feeding tube like that? Because what will granules do? Yes, you put it in water, however, they settle down, correct? So of course, when they drop to the bottom, they'll do the same thing when you aspirate them into a syringe. When you put the syringe down like this, all of them gather toward the tip of the syringe. So of course, they're going to clog the tube, okay? And you can't play dumb and say, oh, doctor, I found the tube suddenly got clogged. It wasn't clogged earlier, okay? And then the doctor will simply look at your MAR, check the medications that you gave, says, oh, was it clogged before or after you gave the Flomax? Okay, they already know, okay, that you clogged that tube. Okay. So Dobhoffs, be very, very careful. Okay, so never take shortcuts with those. They easily clog, and the patient suffers because now the doctor has to pull that out. Patient has to endure insertion of a new one, right? Then put yourself in their shoes. Okay, it's not easy. Can you imagine putting a tube through your nose down your stomach?
So then.
You want to try?
How do you give that then?
Sorry?
How would you give it then?
Well, you're gonna have to be creative. Okay, so small bits at a time so that you don't clog the, you don't get a big chunk, right? Yeah, so little bits at a time. So you may have to give that over 6 cups instead of 1, right? Just to make sure they don't clog. And never mix the medications with the formula. Okay, so medication with water, formula only. Are we clear? Okay, do not mix both. Monitoring the patient, you have to make sure that the stomach is emptying. So even if the patient is on a continuous feeding, you have to check residual every 4 hours. Okay, and then simple. Okay, so someone who's eating, right? So they're not chewing, you're feeding them artificially. So what do you do? Well, how do you assess if they're empty? Okay, feel the stomach. Okay, look at the stomach. Belly's getting distended. That's your evidence, right? It's not empty. Okay, feel it. Palpate the abdomen. Listen for bowel sounds. Okay, assess whether or not they had a bowel movement or passing gas. Okay, that's your proof that there, whether or not there is peristalsis.
No, you just answered my question. That was me.
Okay, and then maintaining tube function. Again, what do we do before and after using it? Flush. Okay, flush before and after using the tube. Whether you're using it for medication administration, you're using it for feeding, or you're using it to check placement. Remember, you check for gastric contents, right? To check for pH. Before and after using it, flush it again. How much do we flush? 30 ml. Now, in the case wherein the patient is on dialysis, for instance, right? And they have a feeding tube. Now, dialysis patients, how many medications do these guys normally have? Like 15, 20. How much should you flush in between medications, therefore? Because if we're talking 15 and there's 30 ml each time, how much is that?
Like 2.
That's a lot, right? Just water alone, just flush alone. So the rule can be bent a little bit. Okay, so if it's between medications, you only give 5 to 10 in between. Okay, you don't have to give 30. So you only give 30 before the first one and then 30 after the last one. Okay, but between medications, you can give either 5 or 10. Okay, in between medications. Okay, so that you don't get the patient bloated. Because that's easily what 400 or 500 ml just the flush if you use 30. Are we clear?
That's every patient or just dialysis?
Any feeding tube.
Okay, so if they have 15 meds, Professor, and you're saying we should be technically putting 1 med per cup. So after I give that 1 med in the 1 cup, I'm flushing.
5 to 10 ml.
Okay.
But we can see it now, that's a lot. So before you flush with 30 and in between meds, you give
5 to 10. Rather than 30. Because the rule is 30. So we don't do 30 in between meds. Because that's easily 500 ml. Right. All right.
5 to 10.
Oral and nasal care. This obviously is if the patient has a nasogastric feeding tube. If they have a PEG tube, then no problem. There's no nasal care to talk about. However, since these patients are receiving enteral nutrition, that means, are they getting anything by mouth?
No.
No. So
Oral care.
oral care is very important. Make sure they brush their teeth just as any normal person, okay, even though they're not chewing anymore. Monitoring, preventing, and managing complications. There's a list of medications complications in the textbook. They're in the chart. They go from dumping syndrome to malabsorption to pyloric obstruction to hyperglycemia, etc. Tube removal depends. Which tube are we talking about? The rule is whoever inserted it can also remove it. So, who can insert a Dobhoff feeding tube? A small boy, a doctor, or an RN. Okay. Now, follow Nurse Practice Act for your state. Down south, where I came from, we inserted Dobhoffs ourselves. Here in the Northeast, only providers can insert them. So therefore, who can? Okay, so again, the rule is whoever put it in can also take it out. So if a doctor put it in, then doctor must pull it out. Same thing for G tubes, okay, peg tubes, gastrostomy tubes. A doctor put that in, a doctor will pull it out. Okay, so this is kind of the first two, actually three are already found on the previous slide. For signs of dehydration, remember, although these patients are receiving liquid nutrition, it doesn't mean they don't need water. Okay, so formula is formula, water is water. So if you're on a continuous feeding, the doctor will need to order how much water to flush. We call that free water. So that's different from the water flush you give in between medications, okay? So this is regular water. So it can either be 1 to 300 ml every 4 to 6 hours. Again, there are
100.
yeah, it can also be 50. Because let's say a patient has heart failure, it may be 50, right? Depending on the patient's needs, but they need free water, all right?
So 1 to 3, right?
Again, it varies. There's really no set. It depends on the patient's needs, okay? So there should be, my point is, are we giving free water? Yes, the frequency and amount will vary. Okay, there's no set frequency and amount. Yes.
There are some new feeding with Gangon feeding. There's some new feeding. It doesn't, the former feeding the old one come with.
Comes with water.
But the new one doesn't come with water. Just,
Oh, really?
yeah, the new pump.
Oh, then in that case, then there's other ways to give water.
It just-
Yeah, just doesn't have to be a pump. Yeah, you can always give them water manually.
So, Professor, is this being flushed like over, like, let's say you finish the feed, is it flushed like in between? Is it flushed after the feeds are given?
Well, rule is again, what do we do before and after using it?
Flush 30 ml.
No, the free water flush.
The free water.
Again, the frequency and amount varies per patient. So there is no set rule that you flush when 100 every 6 hours. There's none. That decision is made by the provider, depending on the patient's need.
So for hydration, basically.
Correct, yeah. Just like any person, even a dog needs water, right?
Right.
Yeah. All right. So we check for problems. We have elevated glucose level, which means is the formula appropriate? Probably not. Decreased urinary output, what could be a cause of that?
Decrease.
Decreased urinary output. Miss
The kidneys are not
Bolanli,
The kidneys are not filtering what
if you put that phone away, you would know. So what about decreased urinary output? What could be a cause of that?
kidney problems, not.
What else?
Heart. Heart
It's not filtering. And heart failure.
Could it be dehydration?
Yeah.
There you go.
That's right.
Sudden weight gain,
Fluid
fluid overload. Okay. What about periorbital or dependent edema? Fluid overload. Signs of infection. Where exactly is the infection here?
Maybe abdominal.
Abdominal through the.
Maybe, but not very likely. It's very rare that they get an abdominal infection. Even though they have a peg tube, no, coming out of the abdominal walls, very, very rare that they get an infection there.
How about the infection in the lung?
Yeah.
Very. Most common infection is pneumonia. Aspirate. So that's top one. Of course, we also look for, just in case there's some local infection, okay, at the exit site. Always check for gastric residual volume. How often again? Every 4 hours if for a continuous feeding. But if it's interrupted, let's say the patient is only on, let's say they were NPO. Okay, so let's say Miss Tuba has a peg tube, but then she's here for GI bleed. Are we gonna feed her? No. So she's gonna be NPO, correct? Probably getting IV fluids instead of feeding. So how often do we flush that tube now? Every 8 hours. Okay, because we need to keep that tube patent. Flushing it is not the same as feeding them. Okay, we're just flushing the tube, which is only 30 ml. All right, we just need to make sure that that tube remains patent. Yes, sir.
I'm sorry, you say for continuous feeding, check every 4 hours. And then you say something.
Yeah, either flush, check, don't forget to flush afterwards though. Yeah, we check this gastric residual volume every 4 hours if it's continuous feeding.
Right, and then you said, what's the other one?
Okay, if there's none, no feeding,
That doesn't work.
every 8 hours.
Thank you. Sorry.
All right, now unlike fluid and electrolytes in heart failure, kidney failure, how often did we check the weight? Daily. This one, if you're checking nutrition, it's weekly. Okay, there's no point in doing daily weights for nutrition. Okay, you can't evaluate nutrition like that. Okay, it should be once a week. Of course, same day, same scale. And it's automatic whenever there's a artificial feeding order in Epic. It generates an order for the dietitian to automatically see the patient. Same thing also if a patient comes in because when you enter the height and weight, it will calculate the IBW, correct? No, the BMI. Okay, so any BMI that's either high or low is a flag, will pop up on the dietitian's screen. Okay, meaning they need to see that patient. They don't need an order. They will automatically evaluate that patient. Again, either a BMI of too low or too high. Never speed up your feeding. This is applicable for enteral and parenteral nutrition. They do not change the rate. If it's late, it's late. Too bad. Don't let it happen again. Okay, we already mentioned, do not mix medications with the feeding. They should be mixed with water separately. All right, the ideal setup is, of course, the closed system. I showed you a picture on the recording. Okay, a closed system ensures that there is no bacterial contamination. An open system wherein you open the bag, put the formula in there, open the second bag, put the water in there. That is high risk for infection because there's somebody who will take a shortcut, won't wash their hands, will use the same glove they used to empty the urinal, for instance, or to do something else, and then they're too lazy to change gloves and wash their hands. True or false? Okay, normal bowel elimination. Since they're eating formula, what is the expected bowel movement?
So diarrhea.
That's actually not true. Babies eat nothing but formula. They don't get diarrhea. They get soft stool, sometimes get constipation too. Yeah? Or moms here.
Why baby
Yeah.
get constipation because there's much iron in their feeding.
Okay, that's my point exactly. So it isn't normal for patients to have diarrhea on tube feeding.
No.
So we have to investigate what's causing the diarrhea. Is it formula intolerance? Is it too much feeding? Okay, or if we eliminate all the other causes, then we'll test the stool for infection. Again, importance of water. Okay. What position should the patient be? Any, whether it's nasogastric or peg tube, always 30. Right. No, this is low. For no, sorry, semifinals. The 45-degree is acceptable, however, because if the patient is bedbound, that's not good for pressure injuries. Okay, so 30 is better.
Professor,
Yes.
and someone has said 30 to 45 days semicolon is okay for G2 program.
Yeah, well, but which is better, 30 or 45? 30 is better.
So when would you put them down after the feeding? Like,
Never.
time frame?
Never.
They stay like that.
The patient is never flat. The lowest you can put them is 30 degrees. Never lay them flat.
Time to stop the feeding or off the feeding.
Those are brief periods, those are acceptable, meaning when you're turning the patient, right? Yeah, so I mean, that's a few minutes, okay? But not like hours, okay? Never put them flat. Never. They don't like it, too bad.
They can aspirate, right?
Yeah.
Yes.
No,
Because they have a feeding tube for a reason. Okay?
If I'm feeding, they cannot ask for the blood. But
They
they
say
have-
that after the
Again, the book says never lay them flat.
down.
Okay, it did specify, it did qualify whether they're eating or had done eating. All right, and then these are the support. This is for the patient and the family. Not all patients are institutionalized. So if they're at home, then the patient or the family must be taught how to manage feeding tubes. And again, these are common complications: wound infection, cellulitis, leakage, okay. Or our favorite in the nursing home, tube dislodgement. Patient pull it out. If the patient is confused, high risk for pulling tubes, lines, drains, make sure there is a plan in place. Okay, so whatever the facility allows, whether mittens, for instance, or if you had binders to hide the tube, do whatever. Okay, make sure the patient is on either close or constant observation. Okay. We talked about clogging earlier. Okay, so of course, the goal is for the patient to receive optimal nutrition, reach their ideal body weight, no infection, skin integrity is intact. When we say skin integrity, we're talking about the feeding tube site, okay, the exit site. And of course, preventing complications. By the way, these are the same, okay? I know it says, keeps saying enteral feeding, but this is the same for parenteral nutrition. Okay, so parenteral feeding, of course, is in the IV now, but goals are the same. How often also do we check weights for those on parenteral feeding? Same, weekly. The only thing you, for infection, as far as infection for parenteral feeding, it's what will they have that won't happen in patients with enteral tubes? Sepsis. Okay, so central line associated bloodstream infection, which is more fatal, more life-threatening compared to the infections you get in enteral feeding. I'm not downplaying pneumonia. Pneumonia is serious. Pneumonia is also life-threatening, can also lead to sepsis, but not as fast as central line sepsis. Please listen to the details for parenteral nutrition, let's say, especially the troubleshooting, because we will run out of formula eventually. Okay, there will be a problem somewhere down the road, either a supply chain issue or a
Natural disaster.
yeah, natural disaster. Okay, wherein the patient could not get their TPN. Now, remember, they have no other choice. Okay, it's not like they can eat. Okay, they were put on TPN for a reason, right? That means, can they absorb nutrients? No, not through the GI tract. That's why we gave the nutrition intravenously. Okay, so therefore they cannot. They have no choice. They cannot eat instead of getting it IV. So if they not get their TPN, you must have a backup, and that backup is 10 to 20% dextrose, because we can live a few more days or weeks without protein and fat, correct? Can you survive without carbohydrates? No.
Carbohydrates.
You starve without carbohydrates. So your carbohydrate is the 10 or 20% dextrose. Right? So if you don't get the TPN, at least get the 10% dextrose. Okay, that will sustain you. That's your carb.
It still sounds so weird, but can you use Gatorade?
Intravenously? No.
No, I mean like, and like.
No.
Like in GI.
Enteral?
Yeah.
I don't see why not.
Right?
Yeah.
'Cause I think I saw this over there.
If the patient, wants to drink, I mean, it's not ordered, but I mean, you can't stop the patient. Let's say they want Gatorade.
Instead of free water.
Not I did though. Not, I meant, not I did.
So wait,
People at home that have to eat, so sometimes they put beer in there.
They can do whatever they want. I mean, we can't stop them. Yeah.
So if it was that, how long you don't to play with that dextrose?
Indefinitely. For as long as you need. I mean, how long do you want to live?
So it's kind of up to survival.
Yeah.
Okay.
Because again, without carbs, you're dead.
Yeah.
So in place of carbohydrates, right?
That is a carbohydrate.
That's right. That's a good-
Dextrose is the carb.
That's why I'm eating this.
For central lines, I also included in the recording the frequency of the dressing change. Okay, a review. We did cover this week 1 for central lines. Was it week 2? Anyway, so let's review. So if it's gauze and clear dressing, how often do we change the central line? The central line dressing? Every 48 hours. If it's clear dressing only, no gauze, 7 days, 5 to 7 days.
Clear is 7.
Professor,
Wait,
is 5 to
7 days is the Bible.
Not clear, 7. It's 7 days clear.